I'm Dr. Anand Kumar. I'm a cardiologist from Lakeshore Hospital, Cochin, Kerala. Today, I want to share a few points regarding some latest updates in the field of hypertension. WHO has said that nearly two-thirds of the total deaths in India are due to non-communicable diseases or lifestyle diseases, of which 27% are due to cardiovascular disease. And these are now affecting the productive age group, that is between 40 to 70 years. For the cardiovascular disease, raised blood pressure or high blood pressure is one of the most important risk factors. And WHO has assessed that despite lot of knowledge and lot of improvement in therapy, the control of blood pressure remains very poor due to low awareness and lack of appropriate treatment by the healthcare. So the prevalence of hypertension has actually gone up by about 10% in males and about 5% in females in the last 3 decades. Now the prevalence is about 38% in men and 32% in women. But 50% of the men and 41% of the women are actually unaware of the condition. They don't even know that they have hypertension. And if you see the control of hypertension, only about two-thirds of the men and about half of the women only get treatment for hypertension. And it is also estimated that only 1 out of 5 patients of hypertension in India are controlled with medications. Now we have different guidelines of hypertension. So I would like to tell that the latest guideline is by the International Society of Hypertension, ISH 2020, Global Hypertension Practice Guidelines. And they have included what is the optimal treatment protocols and what are the essential treatment protocols. So I will tell you some brief details of what is the latest concepts in hypertension. Number 1, the American Heart Association and American College of Cardiology, ACC-AHA, has given a statement in 2021 that the hypertension you can divide into 2. That is stage 1 hypertension, that is the systolic BP between 130 to 140 and diastolic BP between 80 to 89. These patients, if they have no other risk factors, they don't need pharmacological therapy. They can be managed with the medical management. Stage 2 hypertension is systolic blood pressure 140 or above or diastolic blood pressure 90 or above. These patients will need pharmacological management. Again, stage 1 hypertension patients who has other risk factors like diabetes, coronary artery disease, chronic kidney disease, they also will need pharmacological therapy. So it is very clear that stage 1 hypertension, if they have other risk factors, start medicines. If they have no risk factors, continue on non-pharmacological therapy. Stage 2 hypertension, all patients will need pharmacological therapy. A second point, an interesting point now is the study that metoprolol has shown to reduce the lung inflammation and improve respiratory function in patients with COVID-19 infection-induced ARDS. So this is a new study which was published in September 2021. So it is an interesting piece of knowledge that patients who are on metoprolol may have less lung inflammation when they are affected with COVID-19 infection. Should be kept in our back of our mind. At that point, what is the lowest level of BP which is recommended? We all know that even though we say that the best BP is less than 130 by 80, the SPRINT trial has shown that even reducing the blood pressure, systolic blood pressure less than 120, using the latest medicines like ARBs, calcium channel blockers, newer diuretics, and newer beta blockers, has shown that even reducing the blood pressure less than 120 can also be beneficial. Now we have a new trial, the STEP trial, which is conducted in China, about 8,500 elderly patients between 60 to 80 years. They have also shown that when the blood pressure is reduced to less than 110 millimeters, there is an additional 26% reduction in the cardiovascular endpoints. So this is also another new information that even though we say the best blood pressure is less than 130 by 80, in many patients, if they can tolerate, reducing the BP to around 110 to 120 may be ideal in most patients, especially patients with the comorbidities. So another interesting point you should keep in mind. Point number 3 is how to measure blood pressure. We all measure blood pressure using office blood pressure in the clinic of the doctor. But now we know that the best blood pressure is recorded out of office. That is either in the home of the patient using electronic BP machines or a 24-hour ambulatory BP monitor, which is available in many of the tertiary and secondary care centers. So now it is considered that the best blood pressure which we should advise to the patient is to monitor at home using an electronic BP monitors. And it has been shown that the out-of-office blood pressure monitoring or home blood pressure monitoring is most correlated with the cardiovascular endpoints. For every 20/10 increment of blood pressure monitored off hospital, especially at night, there's an increased mortality by 23% and increased cardiovascular risk by 36%. So it is very important to measure blood pressure at home and especially measure blood pressure at the night times, because night BP is the most correlated with the cardiovascular mortality. Another very, very important concept about treating hypertension is the role of fixed drug combination or the combination pill therapy. The European Society of Cardiology says that all stage 2 hypertension patients, it is preferable to start with a combination therapy. And the best combination therapy is an AC inhibitor or ARB plus a calcium channel blocker or a diuretic. So this is the first line combination therapy for all patients with stage 2 hypertension recommended by the European Society of Cardiology. That is a combination of AC inhibitor plus AR or ARB plus calcium channel blocker or diuretic. So if the patient is not controlled, you can add additional therapies. Another interesting point, in the last 2 years, we know that valsartan, certain batches of valsartan were recalled because of the presence of a carcinogen, the NDMA, N-nitrosodimethylamine. Even though it was found as an impurity during the processing and manufacturing of valsartan, later it was found that this is found during the manufacturing process of many other sartans, including irbesartan, losartan, olmesartan. It has so far not been found with telmisartan, but other sartans have been associated with the possibility of impurities, including NDMA. Largest from a Chinese firm or the original innovator brand, that is the Zhejiang Huahai manufacturing plant. It is estimated that if about 100,000 patients were consuming the valsartan from that particular composition and impurity, there will be an additional 22 liver cancer. And so the presence of NDMA is very important. So valsartan, many brands have recalled the valsartan or have switched over to other manufacturing plants. So it is important to know that some ARBs can be associated with this impurity. Finally, a point about the timing of antihypertensive therapy. In the last 1 decade, there has been many studies which have pointed that probably a nighttime antihypertensive therapy may be more effective than daytime antihypertensive therapy. So this was prospectively studied in a study called the Hygia chronotherapy trial, where the same antihypertensive therapy was given either at bedtime or in the morning. And the patients were followed up for an average of 6.3 years. And it was found that nearly 2,000 patients experienced a cardiovascular adverse events, and cardiovascular adverse events were significantly lower in the patient group which received night-time antihypertensive therapy. So this is especially important for therapy using angiotensin receptor blockers, that is ARBs. So probably if you are giving only one drug as an antihypertensive therapy. The best timing for that drug will be a nighttime therapy. And if you are using more than one drug, you can time one medicine in the morning and one medicine at night. Thank you.